Hello, my name's Scot Niglio. I'm a medical oncologist at the National Institute of Health in Bethesda, Maryland. And today I will be talking about the clinical development of immunotherapy in urothelial cancer. Whenever I talk about drug development or cancer in general, I always like to break it down simple and then expand it to the more complex. And I think these three main areas always are my starting points when discussing drug development. I always start with the anatomical location or the largest, the macroscopic area of a tumor, and then going down further to the histology. And the histology overlaps with the cellular, molecular characteristic and genetic characteristics of cancer, and including the tumor microenvironment. Now, when talking about urothelial cancer or ureteral tract cancer, starting out with the anatomy or the anatomical location, the urothelial lining goes all the way up from the renal pelvis down the ureter into the bladder and to the urethra. This lining can become malignant at any point, leading to urothelial cancer. When talking about urothelial cancer, you can't speak about urothelial cancer really without talking about bladder cancer. The majority of urothelial cancer occur within the bladder. So sometimes when I talk about urothelial, you may hear me switching off between the words bladder and urothelial, but it's because the majority of urothelial cancer occur in the bladder itself. When staging urothelial carcinoma, and particularly in the bladder, really the main point is to look at of whether it is non-muscle invasive, muscle invasive, or beyond that, advanced or metastatic. The bladder itself composes of an epithelium and subepithelial connective tissue, the lamina propria, as well as the muscle beneath that, the muscularis propria. The layer below the muscle is the perivesicular fat. So the tumor can start out very small as a TA or T1 without invading the muscle in the non-muscle invasive setting, and then can extend towards the muscle, then becoming a T2. This staging is important for various reasons. One, prognosis. Non-muscle invasive bladder cancer holds a far better prognosis than that of metastatic, and also different treatment options. Non-muscle invasive bladder cancer would lend to more localized treatments, whereas once it's into the muscle, a cystectomy or taking out the bladder as needed. And for metastatic, the disease is no longer curable but treatable with systemic therapies like chemotherapy and immunotherapy. And just touching a little bit on bladder cancer epidemiology, in the US, there's 81,000 new cases and 17,000 deaths occur each year due to bladder cancer. And there's multiple risk factors, including smoking, chemical dyes, rubbers, and textile paints. And now talking more about just the general histology, and the histology that I'm going to focus on is urothelial carcinoma up top. It's right here. But when we're talking about the bladder, 90% of the bladder cancers are going to be urothelial carcinoma histology. The remaining lesser common histologies are going to be squamous cell carcinoma, adenocarcinoma, and small cell with other rarer variants, such as sarcoma, melanoma, and even lymphoma. Urothelial cancer has gone a very long time without much drug development. 1978, we had a breakthrough and with cisplatin. And when I talk about this drug development timeline, I'm going to be talking about mainly systemic therapies. Then in 1985, we got MVAC with a combination of methotrexate, vinblastine, adriamycin, and cisplatin. In 2000, we got the addition of gemcitabine to cisplatin. And then really nothing really happened other than maybe adding carboplatin, but till 2016 and 2017, when we had a breakthrough of 5 additional immunotherapy PD-1 and PD-L1 checkpoint inhibitors. And that include atezolizumab, avelumab, durvalumab, pembrolizumab, and nivolumab. This slide had been updated recently because while these 2 are not immunotherapy, we did have 2 additional drugs added in 2019 for the treatment of urothelial cancer. And that's enfortumab vedotin, an antibody drug conjugate to Nectin-4, and erdafitinib, which is a targeted FGFR3 inhibitor. But for this talk, I will be focusing on the drug development course of the checkpoint inhibitors, specifically the PD-1, PD-L1 inhibitors in advanced or metastatic urothelial cancer. And here are the 5 approved immune checkpoint inhibitors in bladder cancer. And for the PD-1 inhibitors, is pembrolizumab, nivolumab. PD-L1 inhibitors, there's atezolizumab, avelumab, and durvalumab. All 5 of these are approved in the second-line setting after progressing on cisplatin. Their pembrolizumab and atezolizumab are approved also for those that are unable to receive cisplatin in the first line, with the caveat of having PD-L1 expression. And I'll also discuss further, recently pembrolizumab was moved up even in the earlier setting with FDA approval in non-muscle invasive bladder cancer. Okay, so to briefly go through the mechanism of PD-L1 and PD-1 inhibition, tumor cells and even regular cells in your body are going to put out expression of a receptor, PD-L1, and it induces an inhibitory signal to a T cell when it binds a PD-1 receptor when also binding an antigen in a T cell receptor. So when a T cell comes around and sees PD-L1 on a tumor cell, theoretically, it's inhibited from actually killing or inducing cell death into that tumor cell. However, when you block it with a PD-1 or PD-L1 inhibitor, the T cell is able to recognize the antigen with its T cell receptor and therefore recognize the tumor cell as a foreign invader and induce cell death. And briefly, before I get through the upcoming studies, it's important to talk about the side effects of immune checkpoint inhibitors, which are very broad. An immune checkpoint inhibitor can cause essentially an inflammation or autoimmune reaction throughout the entire body. Most common would be inflammation of the lungs with pneumonitis, colitis, dermatitis, hepatitis, but it really can cause inflammation anywhere with even the kidneys, nephritis, bone marrow suppression, as well as glandular autoimmune toxicities to thyroid, induced diabetes, and even neurologic side effects, autoimmune to the nerves, and even to the brain, causing meningitis and encephalitis. The majority of breakthroughs in PD-1 and PD-L1 inhibition have occurred in the metastatic setting in urothelial cancer. So that I will talk about that and some of the pivotal studies that have occurred. The first major study to come out was published in Nature, which was looking at the activity of, at the time called MPDL3280A, or now known as atezolizumab, the anti-PD-L1 treatment in metastatic bladder cancer. And here's a list, a summary of PD-1 and PD-L1 inhibitors approved in the second-line setting after receiving cisplatin therapy, and some of the pivotal studies. The Javelin study for Nivolumab, phase 1b, headed by Andrea Apollo at the NIH, as well as the Checkmate 032 studies for Nivolumab, study 1108 for Nivolumab, and the two phase 3s, IMvigor 211 for atezolizumab and Keynote 45. Going forward, I'm just going to focus on the Keynote 45 for leading to pembrolizumab approval. So in March 2017, pembrolizumab was, they published a study of pembrolizumab as second-line therapy for urothelial cancer, Checkmate 42. 542 patients with advanced urothelial cancer that recurred or progressed after platinum therapy received Pembro for 3 weeks, 200 milligrams, versus investigator choice chemotherapy of either paclitaxel, docetaxel, or benflumine. And here, this slide is showing the pretty balanced nature of the demographics between the pembrolizumab and the chemotherapy groups. And pembrolizumab, when compared to chemotherapy, showed an overall survival benefit of 10.3 months versus 7.4 months, which was statistically significant. And this held up in the 2-year review. And when talking about FDA approvals, then I should mention June 19, 2018, the FDA limited the use of atezolizumab and pembrolizumab for some urothelial cancers, specifically using in the first-line setting for cisplatin ineligible patients who were PD-L1 negative due to poor results. Okay. And so those are the main studies for leading to the approvals for the indications of the PD-1 and PD-L1 inhibitors in the second-line setting of urothelial carcinoma. Now, there's been a lot of great studies done recently, and I'm going to talk about some of those as well. So the studies I've shown you up front have all looked at giving the standard of care, primary cisplatin first for patients with advanced or metastatic urothelial cancer, followed by a checkpoint inhibitor, a PD-1 or PD-L1 inhibitor. And then and in between that, first receiving the chemotherapy and then looking for progression and then giving the checkpoint inhibitor. This study asked the question of whether or not you can give the checkpoint inhibitor immediately after giving the chemotherapy. And so patients with metastatic urothelial cancer achieving at least stable disease on first-line platinum-based chemotherapy were enrolled. Patients were randomly assigned to a double-blind 1-to-1 to switch maintenance Pembro 200 milligrams IV once every 3 weeks versus placebo for up to 24 months. Patients with disease progression on placebo could cross over to Pembro, and the primary objective was determining progression-free survival, and the secondary objectives include determining overall survival as well as treatment outcomes according to PD-L1 combined composite score. And when you look at the switch maintenance study, comparing patients that received the pembrolizumab and switch maintenance versus placebo, obviously they had a higher overall response rate of 23% in the 23% in the pembrolizumab group and 10% in the placebo group. And progression-free survival was significantly longer with maintenance Pembro versus placebo of 5.4 months versus 3 months. And that also asks the question of whether or not you combine chemotherapy up front with a checkpoint inhibitor, and that's what this study IMvigor 130 looked at, which was atezolizumab with or without chemotherapy in metastatic urothelial cancer. It was a multi-center randomized placebo-controlled phase 3. And here's the study schema of IMvigor 130. So patients with locally advanced or metastatic urothelial cancer were randomized to either arm A, arm B, or arm C. Arm A had atezolizumab plus platinum and gemcitabine, carbo or cisplatin. Arm B had atezolizumab monotherapy, and arm C was placebo plus platinum plus gemcitabine. And when comparing atezolizumab plus a platinum-based chemotherapy to the placebo plus the platinum chemotherapy in the first-line setting, there was a improvement in progression-free survival of 8.2 versus 6.3 months. Another interesting study was looking at the combination of a CTLA-4 inhibitor plus a PD-1 or PD-L1 checkpoint inhibitor, and this is in the expansion cohort of Checkmate 32. And this was looking at patients that who had metastatic urothelial cancer in an open-label multi-cohort study who were treated with either nivolumab 3 milligrams per kilogram monotherapy every 2 weeks, or nivolumab 3 milligrams per kilogram plus Ipi 1 milligram per kilogram every 3 weeks for 4 doses, followed by Nivo monotherapy, or Nivo monotherapy 3 milligrams per kilogram every 2 weeks, plus Ipilimumab 3 milligrams per kilogram every 3 weeks, followed by Nivo monotherapy 3 milligrams per kilogram. So there's the Nivo 3 arm, the Nivo 3 plus Ipi 1, and the Nivo 1 plus Ipi 3. I apologize if I didn't get that correctly just in the last 30 seconds. So looking at the overall response, and since this was an open label expansion cohort, able to really look at the overall response rates. And the Nivo 1 plus Ipi 3 had a higher overall response rate than just Nivo alone with 35% versus 20%, and higher than the Nivo 3 Ipi 1 at 28%. And it really is hypothesis generating whether or not to use Nivo 1 or Ipi 3. These aren't statistically significant, but if you look at the graph here, you can look at the progression-free survival of Nivo 3 alone, Nivo 3 plus Ipi 1, or Nivo 1 plus Ipi 3. And the curve for the Nivo 1 Ipi 3 might be a little bit higher. So while this isn't a immunotherapy itself, it is hard to not talk about enfortumab vedotin, or in that matter, talking about what could we add to immunotherapy to improve it. Enfortumab vedotin is one of those drugs, which is an antibody drug with MMAE. The antibody targets the cell adhesion molecule Nectin-4, and currently it's FDA approved in advanced or metastatic urothelial cancer after chemotherapy and immunotherapy, so in the third-line setting. And recently at GU ASCO, they published some very exciting results of study EV103. And this was looking at patient population of urothelial cancer, of locally advanced or metastatic urothelial cancer in a dose escalation study of enfortumab plus pembrolizumab, with enfortumab vedotin on days 1 and 8, and Pembro's on day 1 of every 3-week cycle. And the overall response rate was exceptionally high at 73.3%. So it's very interesting, and looking forward to seeing this combination in the future and future results from this. Now, while I mainly spoke about well, mainly I talked about treatment of urothelial cancer in the metastatic setting. It's hard not to talk about the other FDA approval for immunotherapy in urothelial cancer, and that is pembrolizumab in non-muscle invasive bladder cancer. And that was seen in Keynote 057. Patients with histologically confirmed high-risk BCG unresponsive carcinoma of C2 with or without papillary disease who received adequate BCG therapy and were unable or unwilling to undergo radical cystectomy received pembrolizumab 200 milligrams Q3 weeks for 24 months or until recurrence, progression, or acceptable toxicity. Patients with high-risk non-muscle invasive bladder cancer or progressive disease during treatment were required to discontinue. And out of 103 patients and separated into cohort A, had a complete response rate of 38.8%. And among 40 patients who received a complete response at 3 months, 72.5% maintained that complete response at the last follow-up. And that led to the FDA approval of pembrolizumab for BCG unresponsive high-risk non-muscle invasive bladder cancer on January 8th of 2020. And then lastly, I just want to touch on a couple potential biomarkers. One that's been looked at is PD-L1 expression. And currently, other than cisplatin ineligible in the first line of pembrolizumab or atezolizumab, there's no clinical use at this point of PD-L1 testing in the second line setting. Tumor mutational burden is something that's being looked at, and so is DNA damage repair response and DNA damage response and repair gene alterations. And so looking at the study here, second. So Teo and the group at Memorial Sloan Kettering looked at alterations in DNA damage response and repair genes as potential marker for clinical benefit of PD-1, PD-L1 blockage in advanced urothelial cancer. And they looked at 3 different clinical trials that they had patients on for checkpoint inhibitors and used their in-house sequencing MSK impact to determine if they had DNA damage repair alterations. And they found those that had DNA damage repair had a higher response to PD-L1 inhibitors, PD-1, PD-L1 inhibitors. And when you looked at the overall survival, those with deleterious DNA damage repair mutations seemed to do better with checkpoint inhibitor, and just overall patients with DDR mutations did better than those without. Another potential biomarker that's been investigated has been tumor mutational burden. Here in this study, patients that had a higher tumor mutational burden seemed to have a better response than those that didn't. And again, currently, tumor mutational burden and DNA damage repair do not have a clinical or FDA indication for using when prescribing drugs. And so when looking at urothelial cancer, we've come a long way since we initially got cisplatin in 1978. And there's a lot to expand on currently with making checkpoint inhibitors better, because even right now in the second line setting, response rates are around 20%, and we can definitely do much better than that by either adding in combination, as we've seen even with chemotherapy, other targeted agents, or other immunotherapies and vaccines. And during this time, I want to thank every single essential worker who's out there on the front lines during the COVID-19 pandemic, and especially those in New York City and at Mount Sinai Hospital where I trained.